Good afternoon. Welcome to UCSF Medical Grand Rounds. Today's talk is called Hospital-Based Oncology for the Internist. Our speaker is Sam Brondfield. Sam is Associate Professor of Medicine in the Department of Medicine in the Division of Hematology Oncology. Sam grew up in San Francisco and escaped for 4 years to Harvard as an undergraduate, but then came back and has basically lived out the "you can stay forever" meme, went to med school here, residency, chief residency, Hem-Onc fellowship, and now has been on our faculty for several years. He also got a master's in education, I guess, at Berkeley. Sam is one of the preeminent clinician educators in the department. I think well loved for not only his skill as a teacher and a clinician, but his mentorship. And I know lots of people look up to Sam as a role model, as a clinician educator. For this talk, he'll focus on something that he has done over the last several years, which is build essentially a hospitalist model on the oncology service. And having kind of helped start the hospitalist thing, I'm quite proud of what he has accomplished because he's really transformed the way we think about managing inpatient oncology. And I can tell you, having been at the before and the after, things work much more smoothly today. And I think everybody agrees on that. And the trainees get terrific training and the patients get better care. So Sam, congratulations on doing all that. And we look forward to hearing your talk.
Thanks so much, Bob. And thanks for all your mentorship over the years. So nice to see everyone. This is kind of trippy because I've been to so many of these in the audience and being up here is wild. So nice to see everyone. And thank you for the honor of getting to do this. So I'm going to go a little quickly just because there's some stuff at the end I want to make sure I get to. I have just one disclosure, which is that I got paid to talk about the same topic at McGill and Montreal University a little while back. So objectives today, I want you by the end of this to be able to describe what hospital-based oncology is, or HBO, and the potential benefits associated with this novel model of care, and to apply lessons learned from our own experience with HBO here to your own clinical practice. This is geared primarily toward internists. So HBO is already taken as an acronym, but on our HBO service, we try to be as drama-free as possible, unlike the network. But these are some of my favorite shows, and I show that at the beginning of all my talks for this. So by way of background, a bit about inpatient oncology. Nearly 5 million people in the US are hospitalized annually with cancer, comprising about 12% of hospital admissions. So a lot of people. And at least in one study, these admissions seem to be rising over time. People hospitalized with cancer have unusually high readmission rates compared to average at 30 and 90 days. And for many people, especially with solid tumors, a hospitalization is a seminal event conferring a pretty poor prognosis. And a lot of money is spent on inpatient hospitalizations for people with cancer. So really kind of clinically, financially relevant issues that we're talking about today. And yet there's no standard model for the care of people who are hospitalized with cancer. Traditionally, services on the inpatient side are supervised by rotating outpatient oncologists who come in and do a week or two at a time. We actually did a survey of 50 US comprehensive cancer centers to ask a little about their structures for their inpatient care, and we found a lot of variability. Many were primary services, many were consult services or combo services. Some had APPs, some had hospitalists, so just a lot of variety out there and no real standard for how to do this. And those rotating outpatient oncologists, at least according to one study out of Sloan Kettering, really don't like to attend on the inpatient service. So this was a study of 102 oncologists. I'm going to focus on solid oncology today. 67 of them were solid tumor oncologists. And of those, only 21% felt that caring for hospitalized patients was an efficient use of their time. And only a third of them felt that inpatient care was best directed by someone who knew the patient long term. 84% said that they could adequately direct care while not even on service just by communicating with the inpatient team. And over 60% said if it were feasible, they would give up all inpatient time. So that brings me to the hospitalist model that Bob was talking about. And for time's sake, I'm not going to go through the whole history of the hospitalist model that began in the 90s here at UCSF. But subsequently, Bob and others published an article proposing criteria for implementing a hospitalist-like model within a specialty. And I won't expect you to read them, so I made it larger here. There are 4 proposed criteria, and I just want to talk you through them briefly and mention how they do or don't apply to solid oncology, which is my specialty. So the first criteria is the number of inpatients who require services from the specialty large enough. And we kind of talked already about how a lot of hospitalizations are related to cancer and how that number is on the rise. Second criteria, are most of the pages to this service stat pages? Is this a specialty that's needed kind of immediately? In solid oncology, thankfully for me, not really. So that one's a little bit less so. The third one, are most of the specialists in this specialty needed in the office for many hours? This is certainly the case for oncology, where a lot of them are anchored to their outpatient clinical duties or research duties, and it's not easy to kind of break away and come into the hospital. And finally, is the field sub-specialized, meaning do these physicians take care of a really tiny slice of the field and maybe have less comfort caring for the broad swath of diseases in this area? And I'd propose oncology is kind of the prototypical field that exemplifies this, where we have oncologists taking care of not only one kind of organ system of cancer, but even one tiny cancer within that organ system. So there is definitely the application of this criterion to oncology. So overall, I think we're pretty good specialty for thinking about having a hospitalist-like model that may be helpful. So a little more on specialty hospitalists, meaning hospitalists who have dedicated their career to inpatient care of patients within a certain specialty. Within the literature, there are various proposed factors that support the need for having specialty hospitalists or people dedicated for caring for these patients. For example, and I think about it through a lens of oncology, the tension between outpatient and inpatient responsibilities, imagining just one person having to do all the clinic stuff and the hospital, et cetera. And both having an unwieldy knowledge base in the outpatient setting and inpatient. I think many are aware that the knowledge base within oncology has just been exploding. Very difficult to stay up to date on everything throughout the field, outpatient and inpatient. And since the hospitalist movement, there's been a large and increasing focus on high value inpatient care. And can a busy outpatient oncologist with a big clinical practice and outpatient research really be dedicated to improving the value of inpatient care? I think that's questionable. And stay up to date on the increasing complexity of hospital systems. That's a lot to ask of one person. So the similar kind of dilemma and tensions resulted in the hospitalist movement in the 90s. And that movement has since shown various positive outcomes, mainly length of stay and cost decrease and other outcomes like that. Some literature on mortality as well. And specialty hospitalists actually subsequently started to bloom at UCSF, the most prominent of which have been neurohospitalists that started here under the efforts of Andy Josephson, derm hospitalists under the leadership of Lindy Fox and colleagues. And there are other examples such as OBGYN, ENT, and some subspecialties now of internal medicine like gastroenterology. So this is a growing kind of area of interest. So back to oncology. What is an oncology hospitalist? We have oncology hospitalists on our malignant hematology service here at UCSF. So broadly defined, this is any physician who specializes in the inpatient care of somebody with cancer. And around the country, the vast majority of these oncology hospitalists are internal medicine trained and not oncology trained. They didn't go through a subspecialty fellowship in oncology. And this is an increasingly popular model. One study looked at 26 of these oncology hospitalist groups in the US and found that 7 of them had one or more oncologists or people who had gone through oncology training and decided to fill this kind of oncology hospitalist role. But that's really not a common model to have an oncologist filling that seat. It's really internal medicine trained hospitalists who primarily do that currently. One group at Yale, led by Jensa Morris, has done some intriguing research looking at oncology hospitalists and the impact that they have on clinical care. And their study that they were able to do recently was a nice pseudo-randomized model because they have 2 services at Yale, which is perfect. So they can roll out something on one and compare it to the other. And these services are essentially identical. So they were able to roll out oncology hospitalists or internal medicine trained hospitalists attending on one of their 2 services and keep the other one with rotating outpatient oncologists and compare outcomes. And they found that on the hospitalist service, there was significantly decreased length of stay and early discharge rates compared to the oncology run service. So this is intriguing. There are other studies coming out from this group looking at educational outcomes that look promising too. So all that to say that the oncology hospitalist model, which is fairly popular, is actually showing some good outcomes and is an intriguing model. So given all that, is there a role for an oncologist like me to do inpatient care? And I hope the answer is yes. So I'm going to introduce you to this term, hospital-based oncologist, which is an oncologist, a term we coined here, who specializes in inpatient care, who has dedicated their career to pursuing inpatient clinical medicine. This is an interesting model because an oncologist can do just objectively some things that an internal medicine trained hospitalist can't in the area of oncology, such as order chemotherapy, supervise oncology fellows, and perform and supervise inpatient oncology consultation. There are other things you might think could go better with an oncologist compared to a hospitalist, like maybe more familiarity with the oncology literature, more comfort with prognosis discussions. I didn't list those there because I feel that a well-trained oncology hospitalist is capable of a lot of that stuff too. So I just listed the objective things that I think really distinguish these two positions. So HBO has not been around long enough to demonstrate clear improved outcomes. So a lot of the kind of predicted benefits come out of the literature from the hospitalist movement and other specialty hospitalist articles. For example, you might predict that if we combined all of the responsibilities into one person, like me, all the inpatient care, ordering the chemotherapy, et cetera, that might improve efficiency, consolidate responsibilities, and can leave the outpatient oncologists to do all their outpatient stuff and focus on research and whatever their priorities are without having to rotate on the inpatient service. You might hypothesize there could be increased patient-clinician satisfaction, trainee education, clinician confidence, expertise. Some of this has been shown in other literature for other specialties and the hospitalist movement. Much of it is just hypothesized and predicted. So there actually is one study that was published out of Brown looking at the HBO model. And you might say, wait a second, Sam, this says oncology hospitalist in the title. And that's because we coined the term here and it hasn't taken off yet. But this is an HBO study looking at oncologists who were hired straight out of fellowship to attend on the inpatient service. At Brown, at Rhode Island Hospital, like us, they only have one inpatient oncology service, so they couldn't do what the group at Yale did and compare kind of roll out on one service to an existing model on another. All they could look at was pre and post data at the time that they rolled out this novel model in 2015. And they looked at outcomes such as 30-day readmission rates, length of stay, hospital discharge, inpatient mortality. And they did have some intriguing findings. They showed a statistically significant 6% decrease in 30-day readmission rate post-rollout, and a concomitant 6% increase in discharge to hospice. So that might explain the decreased readmission rate potentially, and no change in inpatient mortality or length of stay. So I don't think most groups around the US would take this study and say, great, we're going to roll out an HBO model, but it is kind of intriguing and makes me want to look at our own data. So HBO has room to grow. There are not a lot of models that I'm aware of around the country. It's been admittedly a little difficult to kind of understand who's doing what around the country. No like great easy way to do that, but there are 4 HBO programs that I'm aware of. Here, Stanford has a very similar one. And then I mentioned the Brown one, as well as at Mass General, and I'll talk more about that one in a minute. So a little bit about our HBO model here at UCSF. We are the only one that's a consult service, so that's pretty different than the primary services at these other hospitals. We have 3 HBO attending since we rolled this out. We started in 2018, but as I'll show you, it's been kind of a slow rollout rather than sudden like in that other study. And we collectively, the 3 of us, cover 3/4 of the weeks on our inpatient service, and the other 25% are covered by rotating outpatient attendings. And these are the 3 of us, myself and Daniel Kwan and Huat Lim. I do all inpatient for my clinical time. Daniel and Huat I call hybrids, and it's not an insult, it's just the kind of descriptor for their job. They are inpatient heavy. More than 50% of their clinical effort comes from inpatient, but they've chosen to maintain a couple of half days of clinic to maintain that outpatient presence as well. So a little flexibility in the model too. And I'd be remiss if I didn't mention Amy Lin, who's since retired, but she was our first HBO attending here. So we have looked at our outcomes. It's been challenging for a number of reasons, but we've been able to look back 5 years. The mechanism that we've been using in our division to look at this sort of data has not allowed us to go back pre-implementation, but we're working on that, and I'm optimistic. So I only have data since kind of the rollout was happening. We are able to compare, because we're a consult service, the consult cases to kind of oncology admissions where we weren't consulted, which is kind of an interesting comparison to see is an effect kind of hospital-wide versus related to our consults potentially. But that consult structure also makes it challenging to directly link our service to outcomes because we're not primarily doing a lot of the stuff that affects outcomes of patients. And then the pandemic was certainly a confounder during this rollout as well. But we looked retrospectively at the number of consults we got, the case mix index, which is a reflection of the complexity of the patients on average, and mortality in the hospital, 30-day unplanned readmission rate, length of stay, and cost. The first, I'm not going to show you all those in graph form, but I'm just going to show you a couple slides on this. So this first slide is just to show you that slowish rollout that I mentioned. This slide is showing you the percentage of weeks out of 52 per year covered by HBO attendings over time as we started to roll this out. And as you can see in 2018, when the first person started, she only covered less than 20% of the weeks. So you can't really call that a rollout because 80% of the weeks are still covered by rotating outpatient oncologists. It took us till 2020 to get over the 50% threshold of covering half of the weeks. And then now in 2024, last year, 75%. So I show you this because in the graphs that will follow, you can see how any trends might mirror this kind of increase in weeks covered. So the first thing I'll show you is number of oncology consults or cases per year. The blue line is consults, so number of consults that our service received per year from 2019 to 2023. And then the orange line is that comparison group that I mentioned of hospitalized patients with cancer where we were not consulted. Interestingly, this helped me understand we're consulted on about 50% of cases of folks who are admitted with cancer, which is interesting. But you can see over the course of the rollout, the number of consults increased significantly over those 5 years, whereas the number of people hospitalized with cancer who we weren't consulted on trended up but didn't increase significantly. And you can see the lines diverging. So I'm not quite sure why we're getting consulted more. I hope that we're kind of inviting more as our culture kind of changes, but we'll look at case complexity on the next slide. That also might contribute, or is there a culture shift toward consulting more in the hospital in general? I'm not sure, but just interesting data to see this mirror the number of weeks that HBO is covering. So this slide is case mix index. This is a measure of complexity of the patients on average. And again, blue line is consults to our service, orange line is hospitalized patients with cancer where we're not consulted. And there's been a statistically significant increase in the complexity, the average complexity of the patients that were being consulted on over the course of this time, and yet no increase or change in the complexity of the comparison cases. So again, just interesting. It probably makes sense that as complexity is increasing, we're getting consulted more. And thankfully, I think we're able to handle this complexity, and it's been a really interesting experience. So the rest of those outcomes, I'm just going to summarize for you. So since HBO rolled out between kind of 2018 to 2020 and still kind of ongoing, consults have nearly doubled. Complexities increased significantly, whereas the comparison group complexity has not. And what I didn't show you, so we looked at mortality. Mortality didn't statistically significantly decrease. So we looked at mortality index, which is the ratio of observed in hospital mortality over expected in hospital mortality. It's kind of one way to correct for kind of how complex or sick the patients are. Because as you saw, we're seeing more and more complex and probably sicker patients over time. And there was a significant decrease in the mortality index. However, that same decrease was seen in the comparison group. So it's probably some kind of hospital-wide phenomenon rather than something specific to our service. I hope we can take a little credit. And then we looked at a couple other parameters. We looked at 30-day readmission rate. We actually saw a trend downward in readmission rate, but it wasn't significant. So we need some more data there, but it's not going up despite the complexity of patients going up, which is exciting. And then we also looked at length of stay index. Length of stay increased because patients are more complex, staying longer. But when we compared the observed to expected length of stay, we saw a trend down and at least not an increase. So again, despite the complexity, we're at least keeping these things under control. And similar with cost, the costs skyrocketed. Probably again reflective of the complexity of the patients. We looked at cost per patient, which also went up, again, probably reflective of complexity. But when we compared observed to expected cost, again, the trend was down and at least not up. So we're hopefully helping to control costs as well, despite increasing complexity of patients. So I think more compelling than that is a survey that we did of hospitalists in 2022. And this was an anonymous retrospective pre-post survey where we asked all the hospitalists who had been here for 5 years or longer and who consult our service how we're doing. They rated satisfaction with oncology consultation on a 5-point scale. And we found that pre to post, there was a significant increase in hospitalist satisfaction from 3.3 on the scale to 4.5. And hopefully even better than that are some of my favorite quotes from this survey. All the quotes I'm going to show you are related to kind of the comparison between pre and post. There were lots of additional suggestions for ongoing improvement, which were really helpful, but I'm just going to show you these. So for example, and these are all hospitalist quotes from this survey, the HPO program has been amazing. The responsiveness, collaboration, and assistance feel dramatically better. I love that we can now get support for patients who are awaiting a tissue diagnosis but clearly have a malignancy. Our oncology attending colleagues and NPs are incredibly accessible and educational. It's been night and day for the better. The service's engagement and willingness to help have noticeably improved in recent years. And finally, my favorite, I like forming relationships with my HPO colleagues. So this is the culture we're trying to build with this change. I wanted to talk for a minute about the impact beyond UCSF that we've had, because we've had a little. Mainly me just plugging the term hospital-based oncology to people. And ASCO, our national oncology organization, has taken it up. And there is now, I helped to co-start this, a hospital-based oncology community of practice within ASCO. This is a group of clinicians and others who are interested in improving and practicing inpatient oncology. And we have 62 members currently, including 40 physicians nationally and internationally. And there's an active discussion board as well. This is our own Daniel Kwan posting about the HPO service and trying to earn some brownie points at the same time. And then this is Carrie Reynolds, who was doing this long before I did. She is a hospital-based oncologist at Mass General who started in 2014. And I just wanted to highlight Dr. Reynolds as a really shining example of what someone can do with an inpatient career in a specialty like this. She, as part of her HBO career, started this severe immunotherapy complications service at Mass General, and it's been incredibly successful, a really cool inpatient model for management of a specific set of conditions, and she and her group have published over 170 articles on this since she started. So just a really cool example of a possible career that someone can build in this space. And although we're not Carrie Reynolds, we have some innovations that we have been able to accomplish here at UCSF as well. I'll just show you, for example, some abstracts that we've presented nationally around our kind of model structure. We started rounding a couple days a week with radiation oncology and neuro-oncology, which has been a really interesting model to pursue. We've looked at some educational sorts of outcomes. And we've also looked at some clinical outcomes in spaces where, for example, guidelines don't quite touch. And we've also presented our findings that I showed you earlier nationally too. And we also have some manuscripts. I'm going to circle back to those during the clinical kind of tips portion. So that was a lot of kind of data to just support this model and some of the history. Why would anybody do this? Like, why would anyone like me, after finishing an oncology fellowship where you train to have these longitudinal relationships with patients, why would you then choose to not do that and do an inpatient career? I think similar to hospitalists, those of us who have chosen to do this really enjoy intensive clinical time followed by time away from the hospital. We are fulfilled by helping very sick people. Not that outpatient oncologists don't do that, but these are kind of the sickest folks in our field. We love a good diagnostic conundrum. We value efficiency and quality and high value care, and we like focusing on that and having the space to actually push that forward. We love collaborating with and teaching other people, and we love and we have to be lifelong learners, because as essentially a general oncologist who has a decent understanding of most types of cancer, I'll never be Hope Rugo or Laura Huppert in breast cancer, and I always love talking to them and others and just continuing to learn about different fields of oncology. So you have to be kind of a humble lifelong learner if you want to do this. And lastly, I mentioned you kind of sacrifice longitudinal patient relationships, though Daniel and Wachter have found a hybrid model where they don't really have to. But for me, I have. And part of that is because during my training, I realized that taking care of patients and developing those relationships in that way wasn't actually what kind of got me up in the morning. It was actually more all of you and getting to collaborate and learn from and work with all of the colleagues here that I get to do. So that's been really amazing. And I still occasionally do have a longitudinal relationship. And I'm not going to talk much about this person who I got to take care of, who sadly died way too young from an aggressive germ cell tumor. But if you're interested, just internet search the Olympics of gay singing. I wrote about this story in the SF Bay Times. And that's me in the middle with my patient. And on the right side, that is not me. That's his partner, in case there's any confusion, who I'm still in touch with today. So that was really what I wanted to say about our service and about how we got to where we are, and what we do on a daily basis. And I wanted to reserve the rest of the time for you all as internists, generalists, or other specialists, to tell you a bit about what we've learned clinically from HBO, and hopefully pass along some pearls to you that might be helpful for your practice. So I'm calling these quick hits, practical pearls for the internist, and there's 4 of them, and they're extremely cleverly named. Wielding the workup, thoughts about therapies, triaging treatment, and diagnosis before discharge. Took me a while and a thesaurus to come up with those. So starting with wielding the workup. So this is based off of a talk that I give for CME around oncologic workups in the hospital. And this is the model that I've kind of come up with over the 5 years I've been doing this as an attending, to depict an oncologic workup. Of course, at the middle, you have your usual history and physical, you have your basic labs, you have appropriate serum tumor markers, and then at the points of the triangle are imaging, procedures and biopsy, and molecular testing. And I depict this as a triangle because one thing I've learned over time is that it's really often not a linear sequence from imaging to biopsy to molecular testing. Often results in one of these areas actually informs the need to do another test in a different area here. And we find ourselves kind of going around and around till we center in on a diagnosis. So just taking these a piece at a time, appropriate serum tumor markers. Sometimes I see people doing these workups and sending off a battery of serum tumor markers like CEA, CA19-9, et cetera. And they're not the most expensive tests. It's not like the worst thing you could do. And from our standpoint, they just lack the sensitivity and specificity in most cases to be diagnostically helpful. They don't really change what we do. After you've clinched the diagnosis, sending the appropriate baseline tumor markers to then trend over time to see treatment effect is a great use of tumor markers. And the PSA is kind of an exception. We actually can use it diagnostically because it's got pretty high specificity when it's significantly elevated. But for the most part, resist the urge if you're stuck to just send off a lot of tumor markers. And I'll come back to that in a minute. For the imaging piece, inpatient, CT chest, abdomen, pelvis is the way to go for staging. There may be additional imaging you need, but this is a great place to start. With contrast is much better than without contrast, especially in the abdomen. And then biopsy. A consult question I get all the time is where to biopsy. It's a great question. And we don't have like literature-based or guideline-directed answers to that question most of the time. So what we say is, or what I think of is just balancing staging with safety, meaning try to biopsy the highest stage lesion to clinch a diagnosis of metastatic cancer if you have METs out there, but balance that approach with the safety of the biopsy. So no way would we say, yes, you have to go after that metastasis, even though it's a very high risk biopsy. Just go for the primary tumor if that's the safest thing to do. So it's just about that balance. And there's not always a totally clear answer, but that's the response we'll usually give, or we'll just use that assessment to tell you you should probably go after that one. Molecular testing, for the most part, don't worry about it. We will do it. But I will just say this is making its way slowly into generalist practice. And you actually can order UCSF 500, our proprietary broad molecular test for tumor-based genetics and molecular testing. You just may not feel that comfortable doing it, which is fine, or know exactly when to order it. And you can always ask us. So I didn't give you a lot of like really clear answers to exactly how workup should always go. And that's because there's not one great answer to this. And I really want to plug the NCCN guidelines to you, which are free and accessible to generalists, resident students. So head to nccn.org, make a free account, and you will be able to see any workup you want for most types of cancer, including the occult primary guideline, which I'm actually a member of that panel. And we've tried to develop it in a way that can help anyone do a workup when you're not sure what the cancer type is yet. So check out these guidelines if you would like. And that's what I've got for you on workups. So number 2 is thoughts about therapies. Just wanted to point out a couple of publications from our HBO group. The first one by a resident here, Nick Thomas, and the second one by a former resident, Jordan Silverstein, who's now an oncology fellow at UCLA. I just point these out because on HBO, we are focused on severe and life-threatening inpatient complications of oncologic therapies. And what does that mean for you, for internists? I think what I would love internists to know about systemic oncologic therapies are these 4 categories: to be able to distinguish between cytotoxic chemo, immunotherapy, targeted therapies, and hormone therapies. And the reason for this distinguishing is because of how different the side effects are. And I don't have time to go through all the side effects of each of these categories today, but I will show you a resource. But I do want to mention for a minute infectious risk and immunosuppression, because this is a common consult question I get. Someone's coming in on therapy X, are they immunosuppressed, or what is their infectious risk? And there's nuance here, but just in general, cytotoxic chemo is the most immunocompromising of these categories. There's even nuance within that category. Some are very immunocompromising, some less so. But most of the infectious risk comes from chemotherapy-induced neutropenia. So if somebody's not neutropenic, they're still at higher risk for infection, but not nearly as much as if they are neutropenic. Immunotherapy ramps up the body's immune system. You can find case reports of weird infections of people on immunotherapy, but for the most part, this does not immunosuppress somebody. This does not make someone at risk for infection. And these are drugs like pembrolizumab, nivolumab, immune checkpoint inhibitors. So in general, not immunocompromising. And I get this all the time. Someone comes in on one of these with a fever. Are they likely to have an infection? Still do the infectious workup, but my baseline suspicion is probably not. Targeted therapies, very heterogeneous group of medications. Most of them don't suppress the immune system meaningfully. There are some exceptions. Some of the tyrosine kinase inhibitors do hit neutrophils and can cause neutropenia and infection. But in the absence of neutropenia, the likelihood of an infection on a targeted therapy, pretty low. And then hormone therapy really doesn't do this in general. Hormone therapies certainly have their side effects. Interestingly, you all actually can order hormone therapies. These are not even considered chemo by a pharmacy at UCSF. So just to kind of put that out there, not that we're telling you to do that, but that infectious risk is just really low, and they're not as dangerous in that respect anyway. So I do think it's worthwhile for generalists to be able to distinguish between these four categories, but not to fret. If someone comes in on a drug name that you and I probably can't pronounce, there's a resource for you. So if you're unsure of whether someone's symptom or sign could be related to the drug that they're on, you can search this online. And my favorite search is just to internet search BC, which stands for British Columbia Cancer Center, plus the drug name. And you will find for most drugs, this really succinct PDF with a table of side effects, the frequency with which they happen, the clinically important ones bolded, and it just can always help answer these questions like, is this headache likely due to this drug, for example? So take this as a resource as a generalist and use it as much as you like. The third of four quick hits is triaging treatment. Another really common consult question I get is, do you recommend urgent inpatient chemo for this patient? And common theme, there's really just no literature or guideline that supports that decision-making. So what are we left with when we get asked this question? We usually go based on clinical urgency, and that has to do with factors like how fast is this cancer likely to be growing based on the information that we have? What sequela is it causing? Like, is there organ dysfunction? And how soon is outpatient follow-up likely to be? But as you can see, all this is kind of gray. There's not like a really clear guidance on this. But what I will say is organ dysfunction is something I've come to respect a lot in terms of its importance around the urgency of inpatient chemotherapy starts. So one message I would convey to you as generalists in the hospital is don't discharge someone if there's evidence of new or worsening organ dysfunction thought due to the cancer, and it's of acute or unclear time course. And that's actually a lot of people. There's a lot of people who come in with organ dysfunction that's unexplained. What I would say is the risk of discharging someone with a significant dysfunction in an organ like liver dysfunction without a good outpatient plan is we just don't know, if we don't have the information, how fast that's going to progress. And I've certainly seen folks get discharged and have to come right back or not do well even outside of the hospital. So examples of organ dysfunction, liver dysfunction, I wouldn't keep someone hospitalized for inpatient start if their Billy was 1.1 last week and 1.2 now. So you just have to use your judgment. Hypercalcemia, altered mental status. If any of this is thought due to the cancer, definitely give the service a call before discharging the patient. Pain itself is rarely an inpatient urgent indication for chemotherapy. And the reason is that unless it's a really chemo-responsive tumor like a germ cell tumor, chemo is just not going to have a rapid effect at all on that tumor and is not going to help address pain. So the better modalities are pain medications and radiation. There are some exceptions, and certainly if the patient's going to be hospitalized for a long time anyway, we would consider chemo to help address any symptoms. But if it's just pain and they otherwise can go, if you implement these other modalities, we will instead try to set up outpatient follow-up for that chemo. And just as more of an FYI, because we talked about in the last quick hit, these 4 different quadrants of therapy, some of those are very expensive and logistically difficult to give in the hospital. It's very easy for us to give cytotoxic chemo in the hospital, like doxorubicin, cisplatin, et cetera. Some of the immunotherapies, like the checkpoint inhibitors, are prohibitively expensive to give in the hospital because there are big discounts to giving them outpatient to the hospital system. However, it's not that we can never give them inpatient. We just have to be really careful and equitable, because if we gave immunotherapy to everyone where the question got brought up, it would be a massive cost to the hospital. These are 5-figure medications for each dose. So that's challenging. And in addition, for insurance reasons, it's really challenging to start many of the oral targeted therapies as new starts in the hospital. So just to let you know, the question of starting inpatient treatment sometimes is complicated, especially if we're talking about something other than cytotoxic chemo. So the last one that I wanted to mention, the last quick hit, is about diagnosis before discharge. This is maybe the most relevant for you all, which is how to approach a situation where you are newly diagnosing somebody with advanced cancer in the hospital, which comes up all the time. And our recommendations for this come out of this paper written by a med student here, Kevin Reyes, going into internal medicine, and led by Daniel Kwan on our service. So I'm not going to talk you through the data in the paper, just kind of skip to what we recommend. So when you are delivering a new diagnosis of an advanced solid tumor in the hospital, point number 1, ask if anyone else should be there first to hear the information along with the person who's getting the news. And then these next 2 points are about what are the key pieces of information that outpatient oncologists from our study wish that their patients knew when walking into that first appointment. If you can focus on just 3 things in the hospital to make sure that you say in a way that people will at least try to remember, acknowledging that that's challenging, that when someone's getting a new diagnosis, it's very emotional. We know retention can be really poor, but if you're going to focus on 3 things, these are those. Tell them what type of cancer they have. Tell them what stage it is if you know. And if you're confident in telling them this, tell them whether it's curable or not. And if patients can walk away with those 3 pieces of information from their hospital encounter with you, they will be hopefully in a better place to start with a head start at their outpatient appointment, so that the outpatient oncologist doesn't have to spend the whole first appointment rehashing this, even though of course they will. If you're not confident in the curable versus incurable thing, don't worry about it. There's many cases where I'm not confident either. Defer it. That's totally fine. But if you know, then definitely tell them. And while you're doing all this, be compassionate and direct at the same time. So I'm going to give you some language that I use. This doesn't have to be the language that you use. This is language I find helpful, but I want you to use what's authentic to you. So here's what I say to people. I have important news to share with you. Is there anyone else you want to be here or on the phone to hear it along with you? You have pancreatic cancer. It's stage 4, which is the most advanced stage. And unfortunately, that means it's not curable. And then pause, long pause for questions or clarifications. Responses to this pause can be pretty variable. Some people, say, okay, what's next? And others say that's enough for now. And any of that is fine in my eyes. So just important to pause and let them react and respond. I try to get to, although nothing will cure it, there are treatment options to try to slow this cancer down. I don't say we have treatments that will slow this cancer down. That's a nuance that's probably not important, but just so you know, of course, like there's a good chance therapies are not going to slow it down. So just important to keep that open-ended. So this is language I use. Again, if it's helpful to you, great. Otherwise, please feel free to kind of modify or do what feels right to you. But the take home on this slide is if you can harp on what the cancer type is, what stage they have, and whether it's curable or incurable, that's going to go a long way, at least according to our study, to help patients move forward to their next steps. So just to finish up and to summarize, HBO, hospital-based oncology, is a nascent field. in my opinion, with immense potential, both academically, research, clinical care, education, et cetera. And I just wanted to thank a few people for their incredible support of not only me, but of this program. Bob, of course, and Eric Small, who initially kind of conceived of this, Andrew Coe for taking a chance and hiring me, and Michelle Murad for just being a fantastic mentor and advocate for this service. So I hope with this discussion, you are now able to describe what hospital-based oncology is and the potential benefits associated with the model of care, and hopefully apply some lessons that we talked about today from our experience to your own clinical practice. And with that, I will thank you for your attention.
Thank you, Sam. That was fabulous. Really inspiring to see not only you presented, but what you and your colleagues have built here. Let me start out with a few. What's the role of the primary oncologist when the patient has an established relationship, and how much are you interacting with that person around treatment because they are the super specialist, as you say you're not, and how much are you interacting with them on matters of prognosis and end of life kinds of decision making?
Definitely a common question I get, and one I've gotten from outside institutions also, about how do we navigate that relationship between HBO attendings and the outpatient oncologist who's been taking care of the patient for a long time. And I would say my main take home there has been flexibility, number one, in that relationship from our end. So here, I've thankfully gotten to know the oncologist. I kind of know by now who wants to be really deeply involved and really guide the care directly, and we're almost not involved, and that's fine, versus who says, you know, inpatient, that's really your purview. I'm here if you need me, but please take the lead, and everything in between. So feeling out the relationship has been really helpful, and the role, as you asked, I think differs depending on what that relationship looks like. But if the outpatient oncologist has a strong opinion about something, it's usually almost always something I totally agree with. There are very rare cases where I haven't felt comfortable giving a therapy that an outpatient oncologist really wants to give as I'm looking at the person in front of me. And in the rare cases like that, I've had to say, you know, I'm just not comfortable giving this, but if you would like to order it, please go ahead. So things like that. But for the most part, it's very synergistic. And then the second principle I've adopted is just having no ego. Like if the outpatient oncologist wants to do something, I just have to check my ego, still clinically discuss it, but it's not about me having to be right. It's about having the discussion and respecting the other person and coming to a decision together.
I can imagine times where there might be some conflict over, have we reached the end of therapies, and or is it one more to try, and how do you negotiate that?
Yeah, most of the time, fairly easily. And I think a lot of that has been relationship building with the outpatient oncologist. But for sure, there are times where the outpatient oncologist will say, there's more to try. And we will say, this person is really, really sick. And it's really just a conversation. It never gets unpleasant. It's just two people expressing their opinions and coming to a consensus. And it's just all about, I think, respect and humility in that conversation.
Great. The curable or not, I was actually surprised by that. It feels like it's so weighty. It's so complex sometimes with all these new therapies. You know, do I know that something is in cure? Things, I wrote an editorial in the New York Times about 5 years ago about that matter, where I used to feel quite confident that there's nothing more, and let's start talking about hospice and things like that. And now, you know, there might be a 1% chance that some miracle drug is out there. So particularly for a generalist to say something is incurable, I guess I'm fine with stage 4 pancreatic cancer, but how about metastatic prostate cancer? How about metastatic breast cancer? How do you navigate that?
Yeah. Another common question, I have a whole CME talk on this topic. I think it's really fascinating. The first thing I would say is incurable does not at all equate necessarily with hospice or end of life. Nowadays, one big shift over time has been managing metastatic cancer, which is incurable in most cases as a chronic disease. So for many cases, that doesn't mean they're going to die anytime soon necessarily. They could, but often can go on for a long time. So I think a big part is what type of cancer is it? So you gave some examples. Prostate cancer, when metastatic, is totally incurable, and yet people can live for years and often longer than that based on therapies now, and the therapies are often very well tolerated. Breast cancer, another example, the median survival of metastatic breast cancer is still in the 2 to 3 year range. So it's not very long on average, but many people can live for a decade or longer with metastatic disease because of the efficacy of some of the novel therapies. And yet there are some metastatic cancers where very few people live a long time. And you just have to know something about the biology, like metastatic pancreatic cancer, metastatic gastric cancer. And oncologists, I think, are quite helpful with that because it's too much to expect generalists, I think, to know all of that about all these different types of cancers. And then there's molecular variability too that affects prognosis. So I think the discussion is important. And key point is incurable doesn't mean hospice. And it still is important, I believe, when you know it's incurable, to make sure the patient's heard that, just so they know what the goal is. The goal is not to get the cancer out of their body. The goal is to control it over time and hopefully give them the best quality of life possible for the time they have left.
Maybe a couple more from me and then we'll open up. You made the point that pretty much everybody gets a contrast CT. You didn't mention PET scan, which seems to be like just everybody gets a PET scan. So tell us about PET scans, when it's useful, when it's not.
Yeah, so I mentioned I'm on the panel for the occult primary guideline, and we have this discussion every year about whether PET scan should make it into the guidelines for workup for cancer of unknown primary. And it always gets shot down on the basis that there's not enough data. There are manuscripts out there that support the use of PET scan in the cancer workup, especially when only when you're in the cancer of unknown primary camp. So not everyone who you could easily diagnose with a standard CT scan, but people where you're still not sure. But the publications are not in high-level journals. The data is not compelling in summary. So we really haven't gotten there yet where there's data to support the use of PET scans in cancer of unknown primary. I think we probably will get there someday as PET scans continue to evolve, but we're really not there yet. And in practice, there's a lot of practice variation. A lot of people do get PET scans in that setting. It's not the worst thing you could do. Some people do get a diagnosis based on a PET scan, but I will say clinically, in my experience, if you've done a standard CT chest, abdomen, pelvis with contrast, and there's no obvious primary, the chance a PET's going to truly reveal the primary is very low, but does occasionally happen.
But PET in the kind of routine workup of known cancer, lung cancer, something in the abdomen, trying to see if it's spread, and the CTs are negative. Any role there, or that's not used for it?
No, thank you. Important clarification. So there is definitely a well-described role of PET scans in the workup of various specific cancer types. So for example, a common example would be non-small cell lung cancer. If you do a CT scan and it's negative for metastases, you have to do a PET scan to make sure that there's no metastases there because they can be subtle. If the PET's positive, they get treated as metastatic cancer. If it's negative, then and only then can you say they do not have metastatic lung cancer. But it varies by cancer type. For example, guidelines for colorectal cancer say do not get a PET scan because just biologically, the chance that a MET will be there with a negative standard CT is very low, just based on the known behavior. So not a clear answer. It really depends on the cancer type.
Got it. My last one was 15 minutes, 10 minutes. We're often, and you guys have made this much easier on us, on people attending on the medical service, but we're often sending people for an onc follow-up, and it's like a big black hole. No idea sort of how long it takes to get, and we're depending on sort of this magic happening there, because we know an onc visit is an incredibly complex thing with lots of orchestration, and it may involve a multidisciplinary team of an oncologist and a surgeon and a radiation oncologist all coming. So can you tell us, and it's a little bit different here because we can't see them, they're not across the street, they're a 20-minute drive away. So can you sort of maybe open the black box and tell us what actually happens when a patient gets referred, and are we too hopeful about the way this is all going to work out when you compare it to the reality of getting this orchestration right?
Yeah, definitely. So when somebody places a discharge referral to an outpatient oncology clinic, the next step is that the staff of that clinic reviews the referral, and they look to see what elements that they need to send the referral through are present and what are not. For example, sometimes someone will not have gotten the necessary scans. And in that case, if they're really basic scans, the staff will sometimes run it by the oncologist in the clinic, and they might say, review the case and say, send a message to the primary care doctor and say, this needs to happen really before this referral can go through. We really can't take a clinic slot for someone at this stage of the workup. Other times they might take that person. But most of the time, the workup's been done, and the staff will then look at the referral, check the insurance to make sure it looks good, and then we'll schedule the patient in a reasonable time frame. That depends on sometimes they review the case with the oncologist who leads that clinic to triage and determine when exactly follow-up should be scheduled and how soon. But that's the general process. On the inpatient side, our consult service, when we have been consulted on a patient where we're a little nervous about the follow-up, we will keep them on our what we call peripheral list, which is a list of patients we review at least once a week. And we can look at the same screen that the clinic staff are looking at and see what's the status of the referral. Does it look like things are going okay? So for those cases, we can serve as a kind of another backup.
Right, didn't know that. Let's open it up. Yeah, and say who you are.
I'm Ella. I'm one of the chief residents in internal medicine. Quick question just off the post-hospital follow-up. We often get suggestions to refer to the undiagnosed cancers clinic. How does that clinic work, and do you also work with them?
Yes, great question. So the question was, there exists an undiagnosed suspected cancer clinic at UCSF. It's a relatively new clinic. It's physically in Berkeley, and there is a referral to that clinic. In the past, just for comparison, that clinic did not exist, and it was very dicey when people would be discharged without a clear diagnosis, because each clinic, like GI onc, thoracic onc, won't usually schedule a patient if they don't have a known diagnosis within that specialty. So it was a really kind of risky period. So this clinic filled a nice gap. You refer to it just like any other clinic. I recommend referring to them either if it's a patient where a biopsy could not have been done, was not done, but you suspect cancer, or if a biopsy is done and pending, and they will take it on, their staff will take a look at things. Often the biopsy comes back before the appointment even happens. And in that case, the physician at that clinic may still see the patient and may even start them on treatment, or they may redirect the referral to the appropriate cancer clinic. I don't actually know how they decide which to do, but either way, they're going to get seen. And I think that's a really nice system that we've been able to put in place.
Great. Other questions or comments? Yeah.
Great.
Say who you are.
Joanne Engel from ID. You talked about how you answer some of the immediate questions when you deliver, a diagnosis, and whether it's curable or incurable. I would imagine that for anyone who is going to ask the next question, particularly if you say it's incurable, they're going to ask you, how long do I have to? Can you share with us your language around that?
Yes, thank you for that question. Asking about a common question following a diagnosis delivery is, how long do I have to live? Another topic I talk about in some of my CME stuff, because I think it's really important, and how to navigate that. So yes, common question. I get it all the time in the hospital. How I approach it, actually, before I even go into the room to deliver news of a new diagnosis, I've already looked up the clinical trial statistics around survival for that cancer in that scenario as best as I can find, because of how common that question is. And it's not that I will say to them, you have a 5-year prognosis, or you have a 20% chance of living to 5 years. I don't usually get that quantitative. What I tell them is, I start with, some people want to know how long they're likely to live and other people don't. How do you feel? Because many people don't want to know, and that's totally fine for most scenarios. If I think they're going to die soon, I will say, hey, I'm really worried. I think we should discuss this. But for most people, I'm totally fine to defer it for then, and they can revisit it outpatient. But assuming they do want to hear, I will then sometimes ask, are you like a real numbers person? Do you want to hear real concrete numbers, or do you just kind of want a general sense? And then I'll kind of follow one of those pathways. And if they want the numbers, I will usually talk about the median survival from the study based on whatever most modern treatment regimen I think they could qualify for. And I'll preface it by saying, this number can't tell us anything about how long you are going to live. It's just an average among a lot of people in your situation. And many people live longer than this. Many people live shorter than this. Here's the number I have for you. I don't want you to walk away thinking this is how long you have to live, because we just don't know. But this is a general sense of what we could expect. And the last thing I say, not the final thing, but something I have learned to add on, is that unfortunately, anybody with advanced cancer, there can be complications anytime. So I just want you to know that even though I think you have a while, if there are things in your life or people in your life that you want to make sure you address, just because we have a lot of uncertainty, I would just start thinking about those things. And that's just because I've been sadly kind of burned before by unexpected complications.
You throw in, this is a field of such active research that there may be something that happens, or that's sort of false hope?
I don't think that's false hope. I think it depends on the situation, because for some cancers, there is a ton of actively evolving research, and that's a great thing to be able to say to reassure somebody. And other fields, there's not a ton of active research. So it kind of depends on the cancer type and how common it is, because it's easier to do great research in a cancer that's common.
Alison, you have from Zoom World?
Yes, absolutely. Have some great questions from the chat, including one about PET scans. So glad you chatted about that already. One was, really loving these pearls that are for non-oncologists who find ourselves still taking care of a lot of patients with cancer, and kind of if you could give a message to non-specialists in terms of most common, one or two missteps or things to remember, like what that might be.
Yeah, great question. Missteps, I would say, just thinking about the different stuff I talked about in workups, I would say most common missteps are probably ordering too much stuff, like MRI brains for people who don't need them, serum tumor markers for people who don't need them, additional biopsies for people who don't need them. So if you're in the camp as a generalist of saying, okay, I've kind of done my first pass, not quite sure what to do next, if you have uncertainty before you kind of just start doing things, feel free to always consult us, and we're very happy to help guide the workup from that step. So I'd say that's probably one. Yeah, maybe I won't waste too much time by trying to think in front of you of a second one, but if one comes to me, I'll let you know.
How do you land on the age-old question of curbside consults? Because I imagine seeing you in the hall, what tumor marker should I send? Is that a question you're comfortable answering, or I need to have a formal consult?
Yeah, I in principle don't have a problem with curbsides as long as they're very general like that. If it's something like, I have this patient, I need advice for this person, I will always ask for them to give me the info so that we can do something formal. One mechanism we have to address consults that don't need a ton of thought is e-consults. We've been doing a lot more of recently, especially in the pre-diagnosis setting where an in-person visit actually can be harmful. You can imagine if someone doesn't even know they have cancer yet, to have an oncologist walk in the room can be pretty stressful. So we're able to do fairly brief e-consults to help guide people, still with formal documentation. But that's how I deal with most kind of quote unquote curbsides now.
Got it. We have time for one or two more to have. Yeah.
I've heard previously anecdotally oncologists who spoke to a patient in terms of prognosis and life expectancy, and the way they phrased it was such that whatever the period of time was that was expected, they said, after this period of time, my ability to help you has diminished. So not saying that life is over at that point, but just saying I can help you to this point, and who knows? I mean, there are other things out there.
Yeah, so just a comment on some language that that you've heard before about prognostically, I can help you up to this point, but beyond that, maybe my ability to do that is diminished. Not language I've personally used, but I just think an example of how heterogeneous approaches can be. I just don't think there's a right answer to how you need to do this. I think it's just, again, from our data anyway, trying to focus on those key pieces of information and then doing something that's authentic to you. That's my approach.
I would hear that as you're going to abandon me at that point. That would not resonate.
And patients are so variable too in what they want to hear and the language they prefer. So I definitely don't aim for something like that because of that risk that someone may not want to hear it that way. So I really do try to stay as concrete and general as possible without taking too many risks linguistically until I know the person better.
Maybe last question. Did you have one? Sorry, go ahead.
Yes. Hi. Great talk, Dr. Brondfield. So I'm Shagin Rivera, I'm a hematologist. Just a small question is, are there any potential differential diagnoses that you would say the patient should not be discharged if you're considering that?
Potential differential diagnosis of types of cancers?
Mm-hmm. Yeah, so the question was, if you're considering certain types of cancers, would you not want to discharge the person until you know what's going on? And in the solid tumor world, not many. There is one, small cell lung cancer, where there's not literature really to support inpatient treatment start, but just based on UCSF's experience with small cell lung cancer, we do. And that's supported by the thoracic oncology group, who will often admit people just for that reason, who are newly diagnosed with extensive stage small cell lung cancer. And the reason is how aggressive it is. So what I tell people in the hospital is if the workup is looking like lung cancer or there could be a primary lung tumor and we don't know what it is yet, we usually counsel them as if it's advanced disease to keep them hospitalized until we know. For that reason, because we may want to start urgent chemo. We pretty much never start urgent chemo. I won't say never, but very rarely start urgent inpatient chemo for non-small cell lung cancer or most other cancer types just because they were diagnosed. Usually also need some kind of like organ dysfunction or something compelling.
About lymphomas or
Yeah.
liquid malignant.
So getting into the heme world, yes, many types of lymphoma and leukemias do require urgent inpatient treatment. So on the solid onc side, lymphoma is often in the differential. So thank you for mentioning that, because yes, if we're worried about lymphoma, which we can often figure out on a pretty quick first pass whether or not that's likely, then until we know what type of lymphoma, especially if they're sick, we'll recommend staying in the hospital. Exceptions are if we have a sense it's probably a low-grade lymphoma and they're not sick, they can usually discharge and wait for diagnosis outpatient.
Great. Sam, that was terrific. Thank you so much.
Thanks for having me. This is fun. Thank you.